Thanks to all our presenters. I really learned a lot, and every one of you shared with us such important information. So as time allows, I have several questions here that I'd like to pose to the panelists. And Tim, maybe I'll start with you. So when you began, you talked about social determinants. And when I think of social determinants of health and the way urban areas address social determinants, I always think of the availability of urban hospitals to have access to many, many community agencies to support their work. How do you handle that in a rural community when you might not have access to all those community agencies to address the concerns?
Karen, absolutely right. We do not have access to those agencies. You know, when it comes to it, necessity is the mother of invention. So we know what we need. We know some of the issues, and I'll kind of give you one example that we had to build on our own, and it had to do with behavioral health, mental health, and addictions. Very limited access in rural areas. We do pneumonia and surgery and things like that, but when we found out so many of our patients weren't advancing, weren't getting their chronic diseases taken care of because of mental health issues, we had to build that program on our own and figure out how to do that. And for years, we kind of turned our back on that. That's not what we do. That's not acute care. But now it is. So some of that you have to build on your own. The other thing is you have to take advantage of the resources that are out there. And a lot of times in communities like ours, social services don't come through a formal program. They come through area churches, other civic organizations that you have to partner with for transportation. And we're all a tight-knit community, so here's the problem. How do we come together and solve that when it will not be a government solution? And we can't expect a government solution. So how do we go about that? One example during the pandemic doesn't tie into social determinants of health, but Kate had talked about it, the lack of PPE. We were running out of masks. We were not able to protect our team and had our team falling ill from exposure to COVID. So people in the community started sewing masks to protect our team and build up that mask supply. And it's probably not the best solution, but in a rural community, that's how you look at it. We look at transportation. Who can volunteer to be able to take patients to a physician's office or to the pharmacy to get the prescription filled? So it's a lot of creative solutions, and there's no one answer to that, but really is the hospital or the physician's practice or the clinic coming together with people in the community to be healthier. How do we do this together, and how do we solve it? And I wish there was one answer, but there's many answers as there are small communities out there.
Thanks, Tim. Great answer. Keith, our next question is for you. In terms of, I know on the BPC, the policy commission that we worked together on, we had many discussions and deep discussions on the challenges of rural communities. And I wonder if you could comment on, so many times this is just viewed as a rural issue. So it's only a problem for rural communities. But after all the discussions that you participated in with VPC, how do we make this more of a national issue as opposed to just having the rural communities be the only advocacy group, advocating to federal and state governments? I was just curious, after our time on BPC, if you had a perspective on that.
Well, thanks for the question, Karen. A couple of thoughts. One is the interconnectedness of our society. I mean, this pandemic and doing things like we're doing here today has really brought that to the fore, that we have a lot to learn from each other. There's a lot that urban can learn from rural and vice versa. And it's not a matter of somebody developing a demonstration in a city and then scaling it down to rural, or rural developing it and scaling up to urban. It's the elements of whatever that we are doing. So if you think about how we work together across organizations or with people in the community, I'm thinking that, for example, the House Ways and Means Committee created a new task force earlier this spring and the task force is on rural and underserved. And I think that's an important recognition that there are a lot of common characteristics down to a neighborhood or community level that you can bring to bear. I think that's the most important ingredient, the two most important ingredients. We're seeing the interconnectivity across urban and rural in a lot of dimensions now. And then second, there's a lot we can learn from each other in pushing things like demonstrations forward under different circumstances will spread that knowledge and innovation much more rapidly than if we keep pigeonholing things and siloing it.
Thanks, Keith. And I have one more for you related to, you mentioned the Pennsylvania Rural Health Initiative and global budgets, and just was wondering if you wanted to comment on BPC, the Policy Commission taking a look at what that means for rural communities.
Well, another good question, and it brings to mind there was an op-ed or a perspective piece, I think it was in JAMA a while back, by some students at Harvard who are working on the Pennsylvania model. And they pointed out something that's really important that I emphasized in my slides, and that's financial stability. Mm-hmm. If you really want innovation, you can do that maybe out of a crisis, and crisis bears forth innovation, but you're more effective if you've got long-term stability in the financing. A model like global budgeting that gives you an annual budget rather than being dependent on services helps with that. The point they made is in the pandemic time, when you're losing a lot of revenue sources that you used to rely on, that can be damaging. But if what you have as a revenue source is a global budget, you've got more security and more flexibility to be able to deal with that.
Thank you, Keith. Very helpful. Ben, I'll go to you now with this question. So we've all watched, horrified actually, with the pain and suffering that we've seen among the Navajo Nation with COVID-19. And I was just wondering if you could offer your perspective on the federal response to that, to those challenges, and what are we doing, or what can we do better to prepare ourselves for, or to prepare the entire population for that, for the coming of the second wave?
Absolutely, and thank you for the question. Certainly, some tribes have been hit hard, quickly, more than others, but this is a growing concern that we hear on calls with tribal leaders as well as Indian urban organization leaders, is how do we prepare? Maybe we weren't hit hard in that first wave, but now we're starting to see COVID creep into parts of the country that weren't hit hard immediately. And just some of the basic informational materials and disseminating those to tribal governments is key. We rely heavily upon the Centers for Disease Control and Prevention as the primary source of information, but to ensure that we're carrying out our tribal consultation and conferring with urban Indian organizations, we've really taken an all-of-government approach all the way to the White House Intergovernmental Affairs Office in scheduling what started out as weekly calls, moving to bi-weekly calls, where we have opportunities to hear firsthand the issues and needs. And I think through those communication chains, that has really provided the largest assistance and direct assistance needed as you reach directly to the top. What I can share behind the scenes is that, it does take a unified coordination group, and that's exactly what's occurring in Navajo Nation, where the Navajo Nation partners with federal government in a unified command to address the issues, whether it's access to PPE, helping to amplify messaging, but to some of the bigger challenges in rural, and happens a lot in rural communities, but perhaps more so in Indian communities, is the housing. Just not opportunities to properly socially distance oneself when you have multiple family members residing in a small location. So there are complications, but I would say communication has probably been the biggest approach, whether it's helping direct resources from the federal government or assisting with those donations that are coming in from philanthropical or churches or whoever it may be. It's really takes an all of government and partnership approach.
Thanks, Ben. And Tim, I'll go back to you because, while Geisinger, where I'm at, is a rural community. And while we know across the country, I think it's 26 states today are still on hotspots. But in terms of based on your experience, what can we look for? What do you think in terms of if you're advising rural communities for now and then going forward in COVID-19 based on your experience? I'd love to hear what you would recommend or what you're seeing and doing right now.
Well, one thing that I tell my peers to be ready for is in rural areas, you do not have a deep bench of anything. You only have so many ER physicians, you have so many respiratory therapists, or so many imaging technicians. When they fall ill and when they are positive and can spread the virus, or when they can no longer work, you don't have the ability to close down an area or draw from a different department. When your ER physicians are all out, you're out of ER. So it's prepare for that and make sure you've got those plans in place. I've contacted with a lot of community hospitals in our area and said, look, and in our situation, so we were hit hard in mid-March. I have 4 OBGYNs. 2 of them came down sick the same day. So now I'm looking at a situation, do I have to go on diversion, or will I soon have to go on diversion because they all work in the same office for my obstetric services? So how do you prepare for that? Just one of the challenges that we see in rural areas that doesn't even come up on the screen in urban areas. So it's prepare that. How do you work together? There are no competitors during a pandemic. So how do you work with other hospitals, other physicians' office, dentist's office working together, us with nursing homes? What are you running out of? What do you need? What do you need from us? We've become this big community crossing state lines from that perspective. So it's a lot of preparation. I'll have to say the first thing for me is protecting my team. The lack of availability of N95s, cappers, pappers, regular masks, isolation gowns has been, quite frankly, appalling. It's been very difficult because if I try and keep my team safe, if I don't have that equipment to keep them safe, it's very concerning for a leader. So how do you make that available? And I've had hospitals, I don't have much, but I'm willing to share with you. And I've had dentist office, okay, we'll shut down for a week to make sure you have the masks that you need, and things of that nature. So it's how do we work together? And nobody's an island in this one. We all have to work together to be successful.
Thanks, Tim. Now I'm going to go to Kate. Kate, thank you for sharing and thank you for participating today with all the other panelists. So I think I wanted to say before pre-COVID, I felt like, working with Keith on the BPC Policy Commission on Rural Health and several other initiatives, I really felt for those of us that are really passionate about rural health, we were gaining some steam and thrilled about that. What does BPC, to the extent possible, see going forward for rural policy? Do you see do we have a strong foothold like we thought we did, or are we looking at a period of distraction, or what are your thoughts on that, Kate, to the extent that you can share?
Both. So I do think that there will be a lot of opportunities for action on things that are important to rural health. I think the biggest one, the one that you're seeing the most movement right now on, really is telehealth. You have, folks are going to look at what this expansion has been, how beneficial it's been, what kinks there were, how we need to work it out. but there is strong bipartisan support for continuing this expansion. And so I think that, that was one of the categories that BPC looked at. That is one of the things that we've really been pushing for in response to the COVID-19 pandemic, and one of the things that I think could be longstanding. You do also see a lot of bipartisan interest, though I think working out the details is going to take time around the hospital infrastructure issues. So, obviously, as Keith mentioned, Chairman Grassley is one of the leading voices in establishing a new model for a rural hospital, allowing additional flexibilities in those communities. And so like there is potential. There are conversations happening, and they are bipartisan. Those are a little slower because the details are hard to work out. How do you work out we had both Chairman Grassley and Congressman Arrington's leading the effort on the House side, both on our honorary task force. And so really contributed to those conversations. But, follow-up conversations, they're continuing to work. They want to keep pushing it, but it's going to take a little bit of time. I think that COVID has used up a lot of oxygen on the Hill, and whether or not we get another package is a major question. Whether or not we pass appropriations bills is a major question, and whether we just have time to do anything else other than address COVID and funding the government through the end of the year is a big question.
Mm-hmm. Thank you, Kate, for that. And Ben, I'll close with you asking one of the questions that came up. As you mentioned, health information technology and the challenges that you see in terms from your perspective. Could you share with us what, if you were to be able to create policy, because we know EHRs are so important to the quality of care and also being able to connect with our patients. Could you share the perspective of what do you see going forward, and what are the policy provisions or the regulatory provisions that you would see would be helpful?
Absolutely. I think to start off, based on what we've learned to date, certainly through tribal health programs who found their own solutions, really exploring various commercial off-the-shelf products for quite some time, and finding ways to share information with the Indian Health Service. We were very fortunate pre-COVID to obtain additional resources from the Department of Health and Human Services to look at, through an independent lens, what is the story behind these various EHR platforms. And in concert with that, we've also been able to work with Department of Veterans Affairs and watch them as they go through their electronic health record modernization. Certainly some of the challenges that we face are in those instances where tribes cover multiple states. Navajo Nation is a good example in working with some of the various platforms as they cover the state of Utah, Arizona, and New Mexico. But what I will say, it is interesting, and we're going to learn a lot through some of the opportunities during this time as we're expanding telehealth operations and working with other federal agencies like the FCC to enter into broadband opportunities on the tribal lands, as well as continue the efforts within EHR modernization. Through some of the COVID-19 funding supplements, part of those are directed towards information technology. So we look forward to the outcomes of the work ahead of us. But I do have to apologize. I don't have a simple answer for that question. I wish there was that magic button that would just make it happen, but it is extremely complicated, as you can imagine. Thank you.
I can. Thank you. So our thanks again to Tim, Keith, Kate, and Ben. This has been, as I said, rural health is a passion of mine, and this has been enormously helpful to me and extremely informative. I also want to thank the staff, the National Academy, and also the staff of the National Academy that has made today possible. And thank you all for attending. We sincerely appreciate it, and we'll continue to work on rural health. Thank you.